Good segue. The mobile stuff is actually a really good segue into our next speaker, Dr. Raymond, who's going to be talking to us about chest pain centers and some of the technology that's supporting this preventative treatment plan. Here you go.
Thank you. Wow, what a great venue to get a message out. And the message is EHAC, or Early Heart Attack Care, and chest pain centers. These are chest pain centers that are growing throughout the United States, 750 right now. We hope to have 1,000 within the next several months or so. And 2,500 is our goal, because there's 5,000 hospitals in the United States, so we hope to get to a certain level where it just takes off by itself. So what are these chest pain centers? Why are they, what are they in function for? If you, we have an app. The chest pain centers are growing by an accelerated rate, and the app we have is from Best Heart Hospitals. It's a free app, and what it does, if you're having chest discomfort off and on, not the severe type, and you want to be checked out, you put in chest pain and you put it on your location from your GPS on your phone, and all of a sudden you find out the nearest chest pain center. Chest pain center is important because it has a pathway for user-friendly, thank you for coming in, let's check you out. In contrast to the mentality of some ERs, Gomer, get out of my emergency room unless you have severe chest pain. So it's a user-friendly, come on in, let's check you out. And it's done within a short period of time. So the app allows us to get there within a short period of time. It goes along with a educational module that we have on the internet, www.heartattack.org, in which you can learn within half an hour what we really mean by early symptoms of a heart attack. And it also, at the end of that, gives you a test, and if you pass it, you become certified, or we say you become deputized. Deputized because in the Old West, sheriff had 2 deputies. In the crisis, you deputize everybody in town. 800,000 deaths in the United States is a crisis every year. So you attack it for the magnitude for what it is. You have to deepen your commitment based on the fact that this is a killer. And I'm going to show you that in half the cases, 400,000, this need not take place. And that's what the strategy of chest pain centers are all about, is to get out that message. And this website, deputyheartattack.org, allows you to understand that. And if you notice, we have a counter. Well, I didn't see it. There's a counter on that every time someone takes that, it becomes deputized. We count that. In the last 4 months, we've had 24,000 people come on board and become deputized into action. And what this means is when they see somebody with early symptoms, they stay with them until those symptoms are being checked out. Instead of enabler, we're trying to convert this to caregivers. And this is the growth with the first surge of trying to get more people understanding. This is within the hospital. These are employees within the hospital, 25,000. We hope to grow this to 100,000 by the end of this year. And we hope to take that and grow it to 1 million by going into the community and educating the people, the public, as well as the people in the hospital, the employees and the like. So the question is, how can we do this? Well, the purpose of chest pain centers is to significantly reduce heart attack deaths in the United States. And one of the ways that we're using, as you can see, is the social media in terms of the apps, the internet, and the analytic aspect on the website itself. So let's backfill this a little bit and find out how do we get to this point. In 1960, mortality, if you came in the hospital with a heart attack, was 30%. 30%. What happened about 1960 is we learned how to do cardiopulmonary resuscitation, and the most important aspect of that was defibrillation. And the theory was if you put all those patients who came in with a heart attack in one area of the hospital, so-called coronary care unit, you reduce that from 30% to 12%. That idea was created by a general practitioner in Bethany, Kansas, not Johns Hopkins and George Washington. It made sense to do something like that. So the mortality is reduced from 30 to 12%. And then within a short period of time, we found out that the reason for the heart attack was a blocked vessel, and the last thing that was blocked causing it was the clot. So if you had a clot dissolver, or if you had a wire that went through that, you open that vessel up within a short period of time, you could reduce damage. But you had to get in within an hour, because after that, 85% of damage was done. And it's almost impossible to get a crashing person with a heart attack into the hospital within that period of time. So in some way, form, or another, even though we have all the glitz in terms of what hospitals are doing in terms of reduced time to get into the emergency room and reduced time to get that wire that opens that vessel up, it's still a crashing illness and life. So we reduced it to 6%, and then something miraculously happened. We were able to reduce it to 1%. And that was because in Seattle, it was shown that if you gave thrombolytic therapy, plaque dissolvers, in the field, you reduced it to 1% because you got to them sooner. But the guy, the cardiologist who was involved with the study, Ward Kennedy, said that was not the most important part of the study. And people say, well, what do you mean? And he said, most important part of the study was when hospitals were doing the study, they did better than when you were not doing the study. It meant that hospitals were not prepared for heart attack consistently in the United States. There was something, the begging question, why? Why weren't we better prepared and the like? Because people were getting variable type heart attack care depending on where you were and the like. So that's what opened the eyes of some of us in terms of reducing it to finding a way to prepare hospitals to reduce heart attack deaths. So that's what the chest pain center movement is all about, was being comprehensive enough in terms of taking care of late care, but also opening our eyes to the fact that there is early care, because Dr. Brownwall found out in his large study that half the patients with heart attacks had beginning symptoms. And he called this, they were heralded by symptoms for hours to days, and even a week before they came in. It was not the crashing, crushing pain, it was that stuttering off and on, mildness, sitting down, most of the time denying it to themselves and denying it to their loved one, and then going to bed and taking 2 aspirins and being found dead the next day and the like. So half the cases were early and the like. So chest pain centers, the purpose was to put together a comprehensive program and to reach out. The problem is when you reach out, you have to deal with the public that has this denial. So we created this EHAC, and that's what the badge is all about. Deputized people that in the midst of someone having these symptoms is standing with them and making sure, recognizing that, and not becoming a neighbor, but staying with them until those symptoms are checked out. We think by taking this across the hospital employees and the public, we can create a system whereby the entire United States will be motivated to bring patients in earlier, reduce that from 800,000 to 400,000, and take this killer out of first place. Thank you.